Okay, so you do the test. Just listen to me for a minute, don't be frustrated. I know you're frustrated, so just get over it. Because you're all gonna be frustrated at some point. I'm frustrated with myself right now. If someone comes in with hearing loss, you can do this, you may find something. If I do the Renee, okay, and I find out that the bone conduction versus air conduction, what, you're gonna find it out, right? So let's just look at this. If I found out that air conduction and bone conduction in both ears, what we call is, it's actually called a positive test, but it's what we call normal, okay? It's greater than the bone. But they're still coming kind of hearing loss, right? Or maybe they're not, but you still do this test and you think, well, your ears must be normal. Right? Because that's normal. But then I stick the Weber up top. And if they have normal hearing, lateralization should go here. Right? They should hear it equally. Or it doesn't go to, they don't hear it greater in one side or the other. Okay? So they don't, their ears are normal. Okay? If you put that on and they hear it greater in the left, they have sensory narrow in the right. Make sense?
Mm-hmm.
That make more sense? Yeah, it does, right? Now, if I do the Renee and bone connection is much, or is whatever, less or greater, so it's about the same as air conduction, the time is the same. And I put this on, and it lateralizes to that same ear, what happens? I have conduction hearing loss there. That's what you need to know. Same thing on the right. Make sense?
But you have to do the Renee's test for like the left side and the right side?
Yes.
Okay.
So do that test first.
Wouldn't you, if you got a bone connection greater than air connection, wouldn't you already know, but without even doing the Weber test, what like, that you have like bone connection to the right side?
You could, yes. You could. That could be your only, the way I'm gonna test you on the test, that's true. That's a true answer.
Now, if you have loss by the Renee test in both ears, why were you even doing the Weber test then?
That was her question. That's okay. I mean, for all test purposes, for the test that you're gonna have, that's a true statement. You know that there's conductive hearing loss, right? It is a lot more complex than that because you can have both, but that's fine. Just so you understand the mechanism of how it works. Is that, did I make it better? No, I really messed it up. Yes?
And now that we've gone over that, could you go over again the actual procedure?
Yes.
The three things that we're
Yep.
doing.
So the Renee and the Weber, right?
Yes.
How to do it.
Yes.
So the Renee, you hit this, and you put it on the mastoid process, and you ask the patient, I'm going to place this on your mastoid process, will you please tell me when you do not hear it anymore? There's a big difference between feeling it and hearing it, but we're trying to actually do the hearing. They think it's the same, but that's fine, just tell them when they quit hearing it, okay? So you hold it, and what you're kind of doing is counting. What I do is I count in my head. It doesn't have to be seconds, it's just a count, as long as you count at the same time. Once they say, I don't hear it anymore, then you say, okay, I'm going to place this in front of your ear, and I want you to tell me when you don't hear it any longer. So you hit it again, and you have them tell you. So the error in this is if I barely hit it the first time and then hit it really hard the second time, right? So you kind of have to watch that, but that's any test there is. The Weber is, you're going to put it here, and you put it right at the forehead, It really doesn't matter how far back, but most people put it right at the forehead. You can do it either way. And you ask them, do you hear it greater in the right, left, or do you hear it equally in both? That's it. Okay? All right.
Ms. Feathers, will you explain one more time why the Renee has to go first? I'm kind of confused.
Yeah. Because you're gonna see if there is actually a problem at all in the ear. Okay? And if the air conduction is the same as the bone, or if the air conduction is greater than the bone conduction,
So this
that's
air-
either a
okay.
normal or it's a sensory neuron.
So you're testing, with the Weber, you're just testing sensory, with the Renee, you're testing sensory and conduction hearing.
No. I'll help you with it,
Okay.
because I really did a poor job. I want you to know most people get this confused with what you're testing. But I did the order wrong, you got y'all confused.
With the Weber, if you don't hear on one side, isn't that bone conduction?
Or sensory neuron.
Is it bone conduction sensory?
Yes.
Yes.
Bone conduction when you put it on the back. Conduction hearing losses. Okay. Okay, so otoscope, to look into the ear. Most important when you do otoscope is when you go into the canal, make sure that you're gentle. So, and for adults, you pull up and back. So, up and back. That straightens out the canal so you can see down it. For kids, you pull down and forward, and that straightens their canal. And as you go into the canal, you actually want to kind of make sure, do you mind if I do it? I'll show you guys on that side, but what I do is I actually look down the canal with my speculum to start out with, okay? And then, so I know where I'm going, and then I can go down the canal. Because if I just shove it in there, which I'm not going to do, it hurts. It's very sensitive. So if you kind of visualize going down the canal a little bit, it's a lot more comfortable for your patient. The other thing is again, you don't want to be doing this because kids will do that. You definitely want to put your hand on their face to control that as you look into the ear. So you're observing the canal, right? You're looking, that's a normal canal. As you look down, right into this is your tympanic membrane that's not in focus yet. That's wax. Okay, you're looking for the cone of light off the tympanic membrane, and so this is actually your cone of light right here that we visualize, because that tells us if that tympanic membrane is sitting where it's supposed to be, or if it's bulging out, or really pushed in or sucked in. So again, cone of light right here. So that's a normal ear versus a really bulging out infected ear, otitis media. Retracted, you don't see the cone of light, or it's distorted up. So we also want to check the mobility of the tympanic membrane. So what you can do is you can put this into the ear, okay, and make a good seal with it and have them kind of close their mouth and blow a little bit, and that'll move the tympanic membrane. Some of these actually, I don't know if any of these do. Like, this will actually blow a little bit of air through this and top the tympanic membrane so see if it moves. So you're looking for the mobility of the tympanic membrane. Pressure on the outside versus blowing on the inside. Okay? Do we need a break or are we okay? We just had a break. Okay. Just had Terry's on, what the heck was Nikki talking about? Okay, so let's talk about the eye. We know most of this. Let's talk about the ophthalmoscope to start with. Well, let's not. Let's talk about the external eye exam. Okay, so you have to look at the eyelashes, you have to look at the lids, you have to look at the conjunctiva, the upper and lower lids. So you just slowly pull that down. Especially if there's a foreign body, you need to look underneath. So you need to know how to flip an eyelid. I don't expect you to do that on the SPs, but you need to know how to flip an eyelid. And when I go get Shelly, I'll show you guys how to do that. Have you ever flipped an eyelid? It's awesome. It's gross, but it's awesome. So you need to know how to do that. You don't have to practice on the SPs. But you just kind of take the end of a Q-tip, kind of push down and pull up, and that'll pop it up, and it'll actually stay like that. Then you just have the patient blink.
Do we have to do that to each other?
No, I can't do it, I was just trying to.
Do what?
Do we have to do that to each other? No.
Well, do you think you should do it on each other, so that first
No.
patient you should try?
Yes. Yes.
Okay, so you're gonna screen their visual acuity. We have handheld, you also have the wall chart with Snellen in most offices, but you also have a handheld that you will carry around if you have one. I recommend you getting one if you don't. But most of them are, you have the patient about 14 inches. Whichever one you buy, look at it. They're standardized to the distance. Some are 14 inches, some are 12, it just depends. Most of the Rosenbaum are 14 inches. And you're gonna have them do each eye. Okay, so right, left, and you can have them do both. But you want them to use their correction. You want them to use their glasses or their contacts. Because you're looking for vision changes with their correction. I know they can't see very well without their correction. You have them read the smallest line possible, and usually what I have them do is the smallest line possible, and then read, if it's the same line for the other eye, just have them read it backwards, because they can memorize it. Right eye, OD, left eye, OS. You know, it's 20/20 or like 2400 is what that person at 20 foot, someone with normal vision can read at 400, so that's really poor vision, obviously. So document it, right eye, left eye, and both in a chart. It's 20/20, 20/30, 20/40. So extraocular movement, I want to know all the movements of the eye. So up, down, right, left, cross, right? So I want to make sure that I also get accommodation and convergence and nystagmus. So to have a person do this, I want to make sure that I have them go, you got to find your own way to do this, but I'll tell you how I do it. Okay? I go across, okay? I zigzag. Okay. Go down. Go across. So I've done this movement. Okay. Right, so I want to get up and down. And then side to side. And as you're going side to side, one, I'm looking for movement, but I'm also looking for nystagmus. And then I want to come in and out, because I'm looking for accommodation and convergence. So, have a patient do this. Someone jump up here. It's not a big deal, so I'm not looking at your guys.
Oh,
Okay, so what you do is you have the patient, you should be eye level with them, okay? And what I tell the patient is, I want you to follow my finger, okay? Don't move your head, just your eyes. Okay? So just a bit. Okay. Okay. So I want you to watch my finger. the far lateral, she has a little nystagmus. That's normal, okay?
Drunk.
Okay.
No, it's from the
So then I'm gonna have her, so I'm looking at her eyes, right? Okay. And then now I'm looking at the pupil size. And they get smaller. Okay? So that's extraocular movement intact. She accommodates, she converges, and there's no nystagmus. Perfect.
So to the left laterally, it's normal to have a little bit of nystagmus?
At the far end of lateral movement, you have a little nystagmus. Everyone does. Well, most people. That's an example of a palsy. You guys can look at that. The cover test, we talked about that already, the cover. So the patient, come back down here. So you can just use your same, I showed you guys this, but I use a card. So the patient will look at it. I would be in front of them so I can see it, like here. If I put my card way out here, they'll fixate on my card with their dominant eye if they have a little strabismus. So make sure you're close to the eye. And you want to have them fixate on my nose. Because you want them, remember, you want them to fixate on an object. Because when I lose this eye and they have a turned in eye here, you want them to fixate with that other eye so that you see it move. So make sure they fixate on your, I always have them fixate on my nose, or look at my nose. Okay? So the corneal light reflex is here, so I can do it from here. So you can't be close because you only get one eye, but you can do it from here. I can see it on you guys from here anyways because the light is room. But trying to check anyone who has a little bit of strabismus. Okay, visual field by confrontation. So I want to check the visual field. How we're going to do this, there's lots of different ways. You can look on the internet, there's 6,000 ways how to do this, but we're going to do it like this. Shelley, do you mind coming down?
All over visual fields.
So usually you and the patient, you got to be eye level, okay? And you want them to cover their one eye or the other eye, doesn't matter. And what you're going to do is you're going to hold up 1, 2, or 5. Okay? And you're going to be in this position here, 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 or here. Okay? And you're trying to get right, left, upper fields, right, left, lower fields. And you're going to ask the patient to tell you what number they see. Okay? So I'm going to have you cover your right eye. You have to be about 2 foot away. Or so. It's way too close.
I'm gonna take my glasses off because they cover my peripheral
Okay.
vision.
Okay, so
And what am I looking at right now? Your nose?
make sure you have them focus here. You don't want them looking to the side because you're trying to get their periphery, okay?
Okay.
2,
1, 5, 2.
good. So she's got really great, that's the thing. You want, and then you want to check bilaterally. So someone who's got any visual field, they won't see this. This will be gone or this will be gone. So that's how you're going to do it. If you're way out here, they're not going to see it. If you find a defect, you're not going to practice this. Don't practice this on the SPs. But if you find someone who's got loss down here, they can't see that, one of the things you can actually do is actually kind of pick up, can you see this? And then you can actually kind of see exactly in this field, where's the deficit? Is it spotty? Or is it just this whole field? Okay, that's one of the things you can do. Okay, that's visual field by confrontation.
I'll just hang up here in case you need to know.
Okay, so direct and consensual is, I'm checking the right eye to see if it contracts, okay, or constricts. And then I'm looking at doing that twice to make sure that her other eye constricts. So you're doing right eye once, right eye second, to make sure that they both constrict. So direct and indirect, or direct and consensual. So 1, 2, 3, 4. That's exactly how to do it, right there. Okay, so pupils, how do we document this? Pupils are equal. They're equal, you got equal pupils, right? So both are equal. They're round. They're reactive to light and accommodation. We did the accommodation test. And that's how you document that. Pupil size you can use by the, you can actually check someone's pupil size. So if I have someone who has abnormal pupils, one to the other, I can actually measure it and say, well, your pupil size is, 6, and this one is 3, and that's more than 2 millimeters, and we may have a problem. Okay, so let's talk about this. Your battery is dead on yours. What? Okay, here's the up-down scope. This is what you need to know about it. There's lots of buttons on it, for one. You know how to turn it on now? You have and Reinhardt's is dead now. Here, mine's working perfectly.
This may be operator error, Professor Fetters.
It could be, because I've had a Renee Weber dysfunction today. Really? Okay, so. How dark is it? Okay, so we turn this on. There's a couple things you need to know. There is, right in front of it, there's a dial. And it tells you, you get 3 different sizes of the circle, okay? What is this? What is this? This is actually to pick a size to look into the pupil. So if someone has really small pupils, you want to use the smallest circle. Most people use, especially in an office, they use the smallest one because it's not completely dark and their eyes aren't dilated. We don't dilate people's eyes to look in it in an office. So you can change that, okay? We also have there's a blue light, okay? A blue light's great if you're really good at the eye to look at the optic disc because it actually helps you see nerve fibers better. That's why the blue light's on there. Most people don't know that, but that's what it's for. Okay? Okay, so this is a slit. So what it does is, if you see something in the back of the eye, you don't really know what it is, and you can turn this on, and if you think you see something, what a slit does is it sees if it actually sticks out. So if you've got something in the back of the eye, you're not sure what it is, it'll distort. So that tells you if it's actually sticking out. So that's what happens when something's sticking out and you put a slit on it. Make sense? Yeah.
Like sticking out towards you?
Yep, sticking out toward you, or in, because it will change your, if I have a straight line and something's sticking out, a line will distort. So straight line, something sticking out, something sticking in. It'll change your line. What else I got here? If you're really good, you can, when you're looking at the retina, this can tell you how, that's millimeters in the back. And you can actually draw it on there. Most people don't use that. All right, then you have filters. So green light is, the blue light, the blue light is actually is for fluorescein staining. You can use your blue light. Your green light is actually to see nerve fibers, because it's a filter for red, filters out your red. That's my fault. So if you don't have a blue light in your office, we talked about for fluorescein stain, you could use your blue light on here, helps you look at the cornea. That's what you need to know. Perfect. Okay. Now, this is the most difficult thing you're going to do, is look at the back of the eye. You also have numbers on the back of this, and you are going to start at 0. So when you play this, you have a dial, and you want it at 0. What 0 means is if I'm looking in the eye, and I'm 20/20, and you're 20/20, if I'm really close to your eye, within 1 inch, because that's how close you are, I should be able to see your retina very clearly. Okay, it's calibrated to see the back of your eye. If I have some correction, I may have to dial or diopter +1 or -1, depending if I'm near or far-sighted. But think of this as I dial in or out, I am moving like a millimeter in or farther away. So I'm getting closer or farther away from the back of the retina. So it clarifies it. It's like a microscope, just adjusting it a little bit closer to the slide or a little bit farther away to clarify what I'm looking at. Because veins aren't flush, the optic disc isn't flush, it's a little bit, so you'll have to kind of clarify it with your microscope or your ophthalmoscope, okay? Now, if I want to look at the cornea, you'd have to set this at +20, because that's where you'd see the cornea the best. Okay. Red is negative. Green is the positive diopters on most of them. Okay, so to look in the eye, one, you have to, can you bring the chair up, because it's the way you have to do it, or you have to be pretty stable. The first thing you're going to see when you look in the eye is the red reflex. So, you know, when you're driving down the road and you're looking for deer, I know you know what I'm talking about. So that's what you look for, so you don't hit anything. You don't look for a deer, you look for the light reflex out of their eyes, because you can't see the deer at midnight. You see the light reflecting out of their eyes, and that's how you avoid hitting a deer. Now, you know, so you won't hit deer anymore, unless they run out and you run them over. But that's what you look for, is the light reflex out of their eye. That's where the ophthalmoscope came from, is they would submerge dead cats in water, and the water would help with the refraction, and they could see better in their eyes. They were looking for that red reflex, just so you know. So if you want to try your cat, just put them in the water, put a light source, look to the back of their eye. I'm kidding. I like cats. Okay. All right, so the biggest thing is you're going to start with just seeing red reflex. And I can see a red reflex from here, okay, if I have light. And you start with the circle, and I'm going to be here, and I'm going to tell you how to have the patient do this, but I can see a red reflex from here. That red reflex is the retina. That's what I'm seeing. It's the reflection of light off the retina. You want to have your patient look straight ahead and focus on a point. So I tell them, focus on that tack over there, or something over there. If they move their head, you're not going to see in through that pupil and see the retina. It's not going to happen. You'll use your right eye to look at their right eye. You use your left eye to look at their left eye. So I want everyone to close their eye and focus at the board. Okay. So what eye dominant are you?
Right.
Which eye did you close? Because that's not your dominant eye. Most people are right eye dominant. How many shoot a gun? right? So most people are right eye dominant if you're right-handed. So it's easier to do it on your right eye if you're right-handed. So what you're gonna do is you're gonna start with your hand up here, your thumb right here. Okay, I know it's hard to see, if you need to stand up, that's fine. And you have to be eye to eye. And as, I'm gonna leave this right at 0. And what I'm gonna do is, will you turn off the first light over there?
You look like you're the other way.
No, I'll do both then. So I'm gonna find that, and you're gonna come in really close. And what you're gonna see initially is the blood vessels. You're gonna see kind of this red and then a line, and that's the blood vessel. And what you're gonna do is I want you to kind of focus it, and you kind of turn one or two to clarify it. I don't care which way you turn it, you're just gonna figure it out what clears it up for you. Glasses, contacts, wear your contacts. They can wear their contacts. You can wear your glasses if you're used to it. I wear my glasses. Some people say it's easier to not wear glasses. You're just gonna have to adjust your refraction on here. If you're really blind, you may have to start at 20 on here. I don't know, it just depends on that. And so I'm gonna find the back of the eye, I'm gonna find a blood vessel, and what I'm gonna do is I'm gonna follow it in until I find the optic nerve and disc. And I'm gonna tell you, you're barely seeing anything in the back. You are seeing just a dot of the eye. This is all you're gonna see. That's it. So, remember the big pictures I saw? You're not seeing that. You're seeing a little spot. So you have to actually kind of move around enough to make a picture of the back of the eye. So there's her, that's her optic disc. And you can see how I'm just kind of moving to see all parts of it. Now, left. It's different, okay? And you are, this is weird. Your patients think you're kind of kissing them, and it's really close. But you have to tell them about it. I have to do this, this is really important.
So you
this
don't
line.
wink at them before you do this.
So left, it's hard because it's you're not that eye dominant. So you gotta come in here. That's how it works.
Your patient will be a little bit blind when they're done at that eye. All you can see is white.
Yeah, because you have just irritated the optic nerve. I mean, I was right on her optic nerve, so it's pretty. So they're gonna feel blind, and it's gonna take practice. You're not gonna see anything. You're gonna see a red reflex. You're gonna just see a glare. This is just practice.
What are
Okay.
you changing on there? Just the night?
All I'm changing is this. It's just trying to clarify the picture. Okay? It's just like when you're fine tuning a microscope. You're just clarifying. It's just click one way or the other for you. Okay?
So the process of fine tuning, does that take into account your vision and their lens?
Yep, that's why you're fine tuning, because you're having to take into that. Because if I took my glasses off, I know that I'm gonna have to change that to, I don't have much correction, but, you know, I'm a -1. So I know that this is, I'm gonna have to change that. So that's why I'm at 0, with her. Well, that's, what am I? Well, a red 2, so I'm at 2 with her on her left eye. Your left eye works? Versus her other, I was at 0, I could see really clear. So I had to change it because her correction was worse in her left eye. That's why it's a little bit different. I can usually tell when someone has really bad vision because I have to move it quite a bit. So I'm correcting for both. Okay? All right,
Don't get frustrated with the eye exam, it's really, really, takes a lot of practice.
it does. Okay, so the ones that are on there that you will visualize and just kind of verbalize it. So you'll visualize it and then verbalize it to the SP that I'm looking at your macula, if you can. So that's kind of why it's on there. So let's do some practicing. Let's give take a little bit of a break. We'll get some, make sure these all work. We'll take a break and then let's kind of go through the exam. You guys practice it. Start with the head and mouth and ears and kind of locate these.
Most providers on their own.
They're usually in the clinic. So, we all have these, and mine's at my house, so I use it on my kids.
Yeah.
But in the clinic, you know, they have them. And we have